Committee this Thursday afternoon, January 29th. And we have some witnesses here on Mental Health Advocacy Day. We deal with issues involving the intersection of mental health and also substance use disorder and the criminal justice system in this committee. There is one bill that we have looked at having to do with victim notification in forensic system. We anticipate seeing a bill from the Senate related to forensic facility and also to competency restoration. But generally, this is an important issue that is for us here, and I'll turn it over to witnesses in a moment. We're kind of at the end of the line, and this is actually where I think other parts of our systems have failed or have not been able to help individuals. And so it's really the upstream from the criminal justice system and this committee is where we'd love to see most of the work being done to address issues related to mental health, substance use, disabilities, and the like. But when it doesn't happen, it comes to us. But anyway, so I have Kelsey Stavset. Is Kelsey?
Yes, here.
Kelsey, sorry, I'm not looking around at the right place. So if you could just join us and please weigh in. And we have about a half an hour total for the three witnesses, but really appreciate you being here today. And appreciate all of you being here today. Thank you.
And Sima is my colleague, and I'll do a little bit of an overview of my intention, and then Sima's going to weigh in with some more specific examples and some data and information here. So
yes, thank you for being here as well, Dr. Ravin. Is it Ravin?
That's right. Thank you so much for having me, Ravin, Simi Ravin.
Ravin, thank you very much. Thank you, Doctor.
Thank you.
So for the record, my name is Kelsey Stavseth. I'm the Executive Director of Northeast Kingdom Human Services, which is the designated agency that covers the 3 counties of the Northeast Kingdom. And I'm also a co-president of the board of Vermont Care Partners, which is the association of 16 specialized service agencies and designated agencies that cover the whole state. And so don't want to go too deeply into that, but just want to give a brief overview and, what's the intersection with mental health, substance use, and developmental disabilities co-occurring that intersects with the judiciary. And so I'll talk in broad strokes and then can answer some specific questions in a moment. So a couple things I want to note is that the designated agencies focus specifically on serious mental illness or severe emotional disturbance when it comes to kids. And so that's the most acute, intense things we see. And we often, not often, but with some frequency, intersect with law enforcement, with the criminal justice system. And so are looked to as what I would describe as being specialty providers with expertise in mental health and substance use, and are looked to do some of the most intense services in the community. And so we really are focused on community-based supports and everything up to until we get to inpatient. And so we will do screenings in the hospital too for mental health to determine if someone needs involuntary treatment in a place like Brattleboro Retreat. And so before we get to inpatient or talking about specialty care like a forensic unit, the state has, in partnership with the designated agencies, really built out a robust crisis system. So we have 988, which is the Lifeline call center that's operating 24/7. We have mobile crisis, so we have people that will respond. You call them, they'll go out wherever. That's a statewide program. We have folks who are embedded with Vermont State Police operating out of the barracks and will co-respond with folks. So, that helps support law enforcement and saying, you call 911, people show up, it's awesome. But sometimes it's not criminally focused. And so can we take the pressure off of law enforcement and respond with a community-based response? And then we do have several urgent care facilities around the state. And as an example, Northeast Kingdom runs a 24/7 urgent care that does mental health, substance use. It's walk-in, and we also have 4 beds for 2 to 10 day crisis stabilization stay, which can be a step up or step down. So if people are stepping out of inpatient, they can come down. So one thing I want to emphasize is that the designated agency system and the community-based system is robust. It does really intense work. And so one part of talking about forensics or specialty care beyond outpatient community base is that you still need to invest in the outpatient community base. We think that is best for folks, keep them in their community for long-term sustainability. it is really important to have a strong community-based provider system. One other thing I want to note is that sequential intercept model, which has to do with the judiciary, is something that's been invested in, I think, more from a time than other resource. But that is really about working with the judiciary to divert folks who do have mental health and substance use challenges out of the criminal justice system when appropriate. And so there's a lot of focus and energy put on upstream in intercepting folks before they get to the criminal justice system. I will say that 2 years ago, the forensic facility came up, and 9 out of the 10, or all but one of the designated specialized service agencies were generally in favor of a forensic unit. And so this was for mental health and developmental disabilities. And there were a lot of caveats that I would put into that, saying like any forensic facility needs to be done thoughtfully. It needs to be built intentionally, because when you talk about involuntary placement, involuntary treatment, any restriction of liberty, I think, cuts across a lot of the Vermont values that we hold dearly. And sometimes the acute nature of the situations we face are beyond a community response. And so there are examples that we can name a few, and I think Dr. Robbins is going to speak to that a little bit, of saying like, we're putting the people who need support at risk, we're putting our staff at risk, we're putting the community at risk when we leave some of these situations in limbo. And so again, having a forensic facility, talking about competency restoration and talking about involuntary treatment is something that with a lot of caveats we'd be generally supportive of. And as the bill comes forward, I'm sure we can have more testimony on what that would look like, what would we need to do if that was going to become a thing. And so not going to weigh in on a yes or no on that yet, but can speak to saying we do need more intensive supports for a very small sliver of instances that rise beyond the community-based supports that we do provide. You want to speak to some of your experience, Doctor?
Hi, thank you so much for having me and for the opportunity to talk with you. I'm going to focus today. First, I'll introduce myself. I'm Simi Ravin. I'm Chief Medical Officer at Howard Center, Vermont's largest designated agency. To give you a little bit of a sense of my professional background, I'm a forensic psychiatrist. So I've trained in adult psychiatry and completed additional training in forensic psychiatry, which is the field of psychiatry that focuses on the intersection of criminal justice and mental health. In addition to my work at Howard Center, I serve on faculty at the Division of Law and Psychiatry at Yale University School of Medicine. I really appreciate this opportunity to talk with you about some areas of concern that I and my colleagues have at the intersection of criminal justice and mental health. And I've identified a few places where we have real opportunity to improve our system and support safety in our community and support the individuals whom we serve. Let's see, I want to make sure to highlight a few areas specifically, and then I'm glad to answer any questions. One of the areas that we encounter fairly frequently is that there are limited mechanisms for meaningful community oversight of individuals who are on orders of non-hospitalization. And a lot of those individuals on orders of non-hospitalization are on those orders out of criminal court, meaning that they have had criminal charges that are resolved in an order of non-hospitalization. And they're for a range of seriousness of criminal charges, and not infrequently for criminal charges for really serious violent acts or violent incidents, and then are mandated to treatment with designated agencies. And when these individuals are mandated to treatment with our designated agencies and don't engage, don't come to appointments, or adhere to those orders, we really have limited mechanisms to support the safety of our community and to support those individuals. I'll just share with you, I was talking about this discussion with one of my colleagues this morning in supervision, and he said, oh yes, and gave me an example of an individual whom he works with who was on an order of non-hospitalization from a resolution of a criminal charge. And this individual had been charged with attempting to and threatening to harm a neighbor with a knife, and then was mandated to treatment with our team, but didn't engage with his care manager or the medical staff member, either by phone and my colleague tried to reach out to him in the community. And we were left with a great deal of concern about this individual's safety in the community. So that just gives an example.
Can I ask you a question about that? I mean, that area has come up multiple times, and I continue to try to understand, well, what can be done about it. And I am continue to do that. It seems in the statute that the answer is if somebody's not engaging in the order of non-hospitalization, that's one of the factors that can weigh into having an order of hospitalization. But that doesn't seem to ever or hardly ever be happening. And do you have any insight on that, number one? And number two, since that isn't working, any other recommendations of what we can look at to address this issue?
I think you might have read my notes that I'm going to get to, but that is exactly the issue. And I think that concern applies to individuals on orders of non-hospitalization out of criminal court, be they resolution of criminal charges for individuals who've been found not competent to stand trial, and on the rare occasion when someone is found their criminal charges are resolved and not guilty by reason of insanity finding, those individuals are often under the mandated care of designated agencies. And so one of the areas of tension that we encounter is when our clinical teams have concern about an individual's significant non-adherence to an order of non-hospitalization, where we have significant concern about that individual's safety for themselves or those around them. We would then complete an application for revocation of that order of non-hospitalization to the Department of Mental Health clinical team. And often that results, that pathway can result in an order of hospitalization. It's for hospitalization for that individual. What we have experienced often is that our clinical team and our concern, we're not always in agreement, and more often than not, we are in disagreement with the clinical team at the Department of Mental Health about whether that petition for revocation should go forward to the court for consideration for revocation. So that is the sort of rate limiting step that we are experiencing. And respectfully, a resolution to that or a solution to that would be for designated agencies to be able to inform the relevant court directly of concerning non-adherence to orders of non-hospitalization.
Really interesting.
So just, can I put attempt to put a finer point on that so that I know I'm understanding correctly? So the designated agency is charged with oversight of this individual who on an ONH.
Yes.
But then when there is evidence of an inability to comply or an unwillingness to comply with the ONH, and you as the designated agency sort of plead that case to DMH, you don't have necessarily the influence that you would like or might need in terms of a change in status for that individual.
The current process, as practiced, though I'm not an attorney, that I've reviewed the statute. The current practice is we then complete an application for revocation of the ONH. and then submit that to the clinical team at the Department of Mental Health. They then review the information we've given them. Sometimes they will have additional interviews, and then they decide whether to go forward and request a hearing to petition the relevant court for revocation. And it is more often than not that we are not in agreement on, we are often more concerned about community safety and the safety of our client because of our proximity to them. And we find this is a real.
You're responsible for them.
Yes, we're both responsible for their care and hold a significant responsibility for their safety in the community, and to report and share their non-adherence to the order of non-hospitalization. That's right.
And just a quick follow-up on that. How is there a typical or a prescribed length of time that this process might take from the time you reach out to DMH and then their decision process and petition the court?
I don't know if there's a time limit. I've found that they are usually pretty prompt in responding to us. And the process if on the rare occasion that we do go forward, that they do elect to go forward to request that hearing, that is a long process. And it can take, my colleagues have, say 2 weeks. My experience, as little as 2 weeks. My experience has been more like 4 or 6 weeks. And often that individual is hospitalized emergently while awaiting the hearing.
Okay, gotcha. Thank you very much.
Barbara, then Karen.
Thank you. I'm wondering, to follow up on Representative Arsenault's questions, there's no sort of like, if there's not agreement, yet another body can help review that?
That is a great question, and we do not have a process like that of appeal or another level of review.
And is this process that's used in other states, or is there process?
So that's a great question. I am familiar with processes primarily in Connecticut and Massachusetts, and I had the opportunity recently at the American Academy of Psychiatry and Law to discuss processes with colleagues from other states, and we seem fairly unique in this. Though, as my colleagues reminded me, each state has sort of developed their own process, so we're all unique. But I don't think that other states have similar processes.
Thank you.
Just to clarify, wondering, this is in statute, or if this is, I'm assuming as a dedicated agency, do you have like an MOU or a contract with the Department of Health? How has that worked? So that's why I'm trying to understand, like, is this a statute thing that we need to work out, or is it more, this is just the agreement that you and the Department of Health have navigated and that needs to be updated?
Well, arguably both, but I think there's opportunity in clarifying the statute to, from my perspective, have the designated agency have more voice about clinical status of people on orders of non-hospitalization. So I think that there is opportunity in the statute.
And has it been explored within the contract or MOU? Again, I don't know the right word, but the agreement between you and the Department of Health.
So designated agencies are written in state statute. We exist as we're private organizations, but essentially fulfill duties of the state. And so we are tasked to take people into our care on behalf of commissioners. And so that's for the mental health commissioner and also the Dale commissioner. And so they are technically in the state's care, but we are designated to support them. And so each year we negotiate a provider agreement, which has a lot of language in there that is fairly set. And then there are statutes that about hospitalization, involuntary. And so those go through DMH and then through the judiciary process with the judge and presenting that. So there are probably a couple of entrance points that would need to be amended to change how that happens. And again, I think Vermont has a preference for community-based options, which I think is a good thing. And to what we're speaking about, the sliver of folks that need more intensive level of care, there probably needs to be thought about differently to address this. Yeah.
Certainly appreciate those, just wanting to understand the levels of that. And so is it that we need to start at the top, or have things been addressed at other levels as well? Or do we need a comprehensive approach? Yeah.
Do you have more, Doctor? You can continue.
I think that through our discussion, I've covered the points I really wanted to emphasize on where there's opportunity to improve our processes. I think I'll just emphasize that this is a narrow group of individuals whom we serve. The vast majority we serve effectively, safely, and in a client-centered manner in the community. And when we have the responsibility to both serve and oversee the safety of individuals in the community who have history of serious violence and significant criminal charges, we have an opportunity to improve our processes. And I think that there's opportunity to improve that through the statutory language on orders of non-hospitalization.
So I have two questions that are not exactly on this topic, but I think you two would be really well.
Can I ask one question on the topic, and then I'll come to you just real quick. And maybe this is a sensitive topic, and you can't say much on this, but I'm curious to understand where there has been this difference of viewpoint where probably revocation of an ONH was sought, and it didn't happen, and then something bad happened. I mean, and then we've actually had the harm occur. And, I know of two, and I know of two situations that involve that. My understanding, and it's really hard to get to the bottom of these situations. Like in Franklin County, there was somebody that at one point had been on an ONH and ended up killing his father. And in a situation in Washington County, there was somebody that either was on an ONH or should have been who did. So it's like, and I'm just, the reason I'm asking is it's hard to find out if there have been these bad situations that makes this salient, a little more salient, and lights the fire under the legislature and the administration to actually do something about this.
I can give you, I'm going to try to give you an example that gives enough salient information that you can see why this is of really profound importance without giving any kind of identifying information. Right. I can tell you that this happens not infrequently, that an individual is on an order of non-hospitalization, and then we've had difficulty getting it revoked through the process that I've described, and then there's harm to that individual or people around them. I will try to give an example without giving any identifying information of someone whom I have worked with. This is a woman in her early 30s who was on an order of non-hospitalization out of a criminal court for a serious charge. I'm trying very hard not to give much any identifying information, so please pardon the vagueness.
No, that's fine. I understand.
Yeah, we became she had a very serious charge that attracted a fair amount of public attention. And I left care with us, wouldn't come to appointments, wouldn't answer phone calls, wouldn't engage with our staff when they went to their residence. where she was living. And we became increasingly concerned because of a history of violence towards others. Thankfully, a history of violence towards others without serious injury. And because of the depth of our concern about the non-adherence, we this is a few years back, just to give some context, completed an application for revocation. And one of the difficulties we ran into was we didn't have a lot of current information about her, how she was doing in her current state, because she was taking a step back and not engaging with us, despite that she had an order of non-hospitalization and a mandate to do so. But we had pretty profound concern. Our colleagues in the clinical team at Department of Mental Health said, we sympathize with you, but we don't have enough information to go forward to request revocation from the court. And so we continued to try to reach out to this individual in the community and to reach her in her residence, in person, by phone, and so forth, without success. And we petitioned a second time. And were unsuccessful again a second time. We actually became concerned because the individual, we learned, may have obtained weapons, not firearms, but knives. And we're very worried about the people immediately around her. Ultimately, our request did go forward. Our colleagues on the clinical team at Department of Mental Health said, yes, this is concerning. We understand you've not been able to connect with this person. We understand the level of risk, and we'll go forward to have a hearing about this. While we were awaiting the hearing, this individual had assaultive behavior towards a number of individuals who were in their proximity, thankfully without serious injury.
Okay, all right, no, I appreciate that. Thanks for that. Finally.
That actually brings up a third issue, which is interesting to think about when you can't make contact with someone, if the failure to be able to make contact could trigger some action because we don't know. So, and that action might thoughtfully be something, not necessarily hospitalization, but some way for somebody to figure out what's going on.
Yes.
So just going to limbo.
I think that's a really interesting point. And it's interesting when you look at what is allowed for revocation of an order of non-hospitalization, typically the outcome when an order of non-hospitalization is revoked is hospitalization, but a wide range of clinical interventions are allowed, and that brings up the possibility of utilizing that more fully, the revocation mechanism more fully for other kinds of intervention or clinical care to support an individual that are not hospitalization.
So I will make this really quick. I know mental health, despite getting increases at times, things are tight and there's more demand than you can serve. I also get concerned when our state contracts out services and doesn't think to, and it's not even Department of Mental Health, it's other departments that are contracting out mental health services. And I'm wondering if, like, when the RFP is out for providing services in corrections, if you have like right of first refusal to put it, or preferential treatment as a provider to bid on these things, so that we're allowing our Vermont resources to have access first to these types of service opportunities.
It's certainly an interesting thought. We don't currently provide services in corrections, but we do, when we have someone transitioning from corrections to the community, we do in-reach to have as little disruption in care as possible.
Yeah, we do have some programs that go into facilities for specific reasons, substance use being one of them. But from a bidding perspective, I mean, we've seen those RFPs and saying like, what's the capacity and ability to do that, which I think is probably what you run up against, but I think it's been considered in the past, but I don't think there's any inside track that the designated agencies have for an RFP.
And my last question is, when public inebriates, when we repeal the repeal to send them back to jail, I was told, oh, like the Howard Center doesn't want to do Act One anymore. And I said, is it that that programs are not being adequately funded to do these programs? And so I guess I just want to hear if designated agencies are looking to not be doing the kinds of programs that Act One was doing. And I don't know if your 4 beds include.
I mean, so Act One is Howard, so I'll defer to Howard on that. But from a public inebriate standpoint, NKHS has a contract for that, but the way it's funded required us to staff it through an on-call procedure because crisis continuums are about being needed when the thing happens. And if you fund it on a volume, or if you have to say like, well, we're not going to pay for people to be there, then what happens is, in effect, the process reduces the efficacy. And so what we found was that for the police, they're like, well, we're not going to wait half an hour if we get there. We'll go to the hospital, we'll go to jail because we got other stuff to do because they're taxed. And so you can't blame them. But to just have someone available 24/7 at a even, just a fairly decent rate is going to cost you $100,000. And so that's just not available. And so what you get is people going to higher levels of care, like the hospital emergency room, which is expensive and has a healthcare cost, or jail, which again is like a fine holding place, but doesn't get to the root cause, and you're probably going to have recidivism. So, we would argue that we are open to doing that. We're a preferred provider for substance use. The front porch is co-occurring. We have people there that we don't do clinical detox. That's intense, and you need medical oversight for that. But in terms of social detox or public inebriate program, we're certainly open to that. I would say that the entrance issue there is funding, which is very limited.
Okay.
Yeah, appreciate
I was wondering if I know there's a third person to testify, and I just don't want
it.
to
There,
step on their toes.
no, there's not much time. So Lindsay, are you going to be back the week of the February 10th isn't there Disability Day? Can we have you on that day instead, so we're not cutting into your time? Because I know I've already set aside that we're going to have some time on that day. So can we reschedule you for that instead?
Yeah, anyway.
We're not rushing you. So thank you very
I'd
much.
be happy to come back, I think, when the bill comes forward, and I think there's more to talk about.
Absolutely, there is. Very.
An overview, so appreciate the time today.
Yeah, we need to see what
Thank you so much.
what they're going to do with it downstairs. So
Thank you.
yeah, it's on the Senate side, S-193. So
Yeah,
thank you very much, Dr. Evan, and
Thank you so much.
everybody. And we are.